السلام عليكم.
عليكم السلام دكتور.
أهلا دكتور.
السلام عليكم شباب.
عليكم السلام أستاذة، أهلا وسهلا.
عليكم السلام، أهلا دكتور.
ما أعرف دكتورة زينب معانا؟
الو السلام عليكم، تسمعني؟
عليكم السلام دكتورة زينب، شلونك؟
الحمد لله. أنا أكو مشكلة ما أعرف الفيديو مالتي ما يبدأ. ما أعرف صوتي واضح؟
صوتك كلش واضح.
الفيديو مالتي is not connecting.
Okay, دكتور لوك موجود؟
Yes, so Luke is here with us. We just had some technical problem and we were trying to sort it out. That's why.
Okay, shall we wait?
I think he is almost ready.
Good evening. Can people hear me?
Yes, we can hear you, Luke.
Yes, very good evening.
Good evening. Thank you for having me. So I'm afraid I've had something of a nightmare with my presentation, whereby I've sent it from my workplace, and unbeknownst to me, there is some sort of encryption put on it, which has meant that I cannot now access it from my home computer. So the presentation I had prepared, I'm afraid I'm not able to access. So we are going to head through the sort of the bullet points I had planned to go through, but depending on how things go, I'm very happy to run this again at a later date if we feel that the presentation is required, because I feel doing speaking about a station which is primarily on finding clinical signs on Teams was going to be tricky enough, and when we add in the lack of presentation, I'm not 100% confident how well this is going to go, but we will see how we go, and we can roll with the punches from there.
Okay, thank you very much, Dr. Luke. Everything, technical errors can happen at any time and makes life more difficult, but I am sure you will be able to over it. Dr. Zainab, if you want to introduce Dr. Luke and to show the attendee the way that this session will go forward, please, Dr. Zainab.
Yes, so good evening, everyone. Today is our first.
Dr. Luke, even if you cannot share your video as well, Dr. Luke.
I'm just trying to do that at the moment. I'm afraid I'm unfamiliar with Teams, so I've got my microphone. I'm working on my camera.
Okay. Take your time. Take your time. Yeah, it's great now.
Yeah.
Hello.
Hello, everybody.
How are you? Nice seeing you.
Yeah, you can see me.
Yeah, now we can see you both. So
Excellent.
Great.
Excellent. Great.
Okay. Zainab, the floor is yours now.
Yes, thank you so much. Thank you. So tonight, good evening, everyone. Tonight is our third workshop, PACES workshop, and I appreciate. Oh, something happened. Yeah, hello.
There is an echo. You just close the old one.
Yes.
Just close one.
Yes, I did that. Yeah, thank you. Sorry about that. So I'm very thankful that Luke has dedicated some of his time to join us tonight to talk about mainly the clinical sessions or clinical stations, and how to pick clinical signs, how to present your clinical signs, and how to summarize them, and what is the best way to present your finding to the examiner, and how to fill your time in the best possible way to allow minimal chance for the examiner to ask any questions. And the other thing Luke will hopefully discuss tonight is what is the best choice of words we could use to describe our patient signs, symptoms, and how to address certain what we call important topics with the patient with the best possible words. So Luke is one of the nephrology registrars at University Hospital Coventry, and he is a clinical teaching fellow as well. And we work together at the University of Warwick, teaching medical students. So Luke, thank you again for being with us tonight. And I appreciate there were some technical problems which have prevented you from presenting your slides, but hopefully we will be able to get through with the best possible outcome. The floor is yours, Luke.
Okay. Well, good evening, everybody. So first of all, a little bit about me. So I'm Luke Antamaniu. I was a UK medical student and trainee. I did my primary medical degree at Warwick, graduating in 2011, and then went on to do foundation training, core medical training, and have completed 6 and a bit years of renal training, coming toward the end of that now. And I'm currently taking some time up as a clinical teaching fellow, which is primarily based with the medical students, but we do teach lots of other people as well. I did PACES in 2014, I believe. So I've refreshed myself on some of the changes, and I'm sure some of our learned colleagues will be slightly more abreast of the PACES 23 changes, but we can touch on those very briefly. But actually, when it comes to clinical stations, it doesn't appear that it's going to have a huge impact on those. Now, I think when it comes to the physical examination stations, and by that primarily what I'm talking about is cardiovascular, respiratory, abdominal, and neurology. These are the 4 10-minute stations you're going to get. And I think whilst there's been lots of tweaks and changes along the way, the ethos of these stations has always primarily been around finding and interpreting physical signs. So there are obviously the 7 domains, the 7 skills which you are being assessed on. But as I can show when I share my screen in a second, the area that repeatedly, okay, we're not sharing screen. So one of the things I've looked up prior to this is the MRCP actually publishes the skill. Sorry
to interrupt you. If you want to share screen, maybe Dr. Hilal can make you as a co-host if you have anything to share.
It's okay. I can just speak through them. That's no problem. So in an attempt to try and garner a bit of information about where non-UK tradies particularly may fall down, one of the places I started was I was looking at the pass rates which they quote on the MRCP website.
Now you are co-host. You can share whatever you want.
Okie dokie. Let's share this one. So effectively, this is published on the MRCP website, and I found it quite interesting in regard to. So this is looking at the pass rates of the most recent diet, and specifically the areas in which people, the skill areas and the domains in which people tended not to pass. And I think the consensus certainly from the UK trainees is that the area where you can most easily be caught out tends to be the identifying physical signs. And I'll speak a little bit about, I think, possibly why that's the case, and speak a little bit about the calibration process and how we can, how knowing about that process may help us in how we prepare for this. But looking through some of these results, as you can see, the pass rates for identifying physical signs, which is going to be the mainstay of what we're looking at in these stations, is comfortably the lowest there. So bearing in mind the 5 skills we're looking at in these stations are going to be physical examination, pretty good pass rate, identifying physical signs.
Look, excuse me. Look, can you put it a full screen, please? Full screen show.
So what am I doing at the moment? What can you see? What can you not see?
We can see, but it is a small, very, very, very small.
Okay,
print.
let me just try and let me I'm not sure if I'm about to get.
Yeah, that's good.
Yeah, that's good. Great.
There we go. We can make it a bit bigger. So going through the skills which are going to be focused on in these 4 stations, physical examination. So this is the process of the physical examination. This is the technique of acquiring those signs as opposed to the signs you acquire per se. And actually, people are doing very well on that. The identifying physical signs, as you can see, is sort of markedly lower. Other areas we're looking at in these stations, your differential diagnosis, which again, a markedly lower pass rate, the clinical judgment, which isn't too bad. And then interestingly, the maintaining patient welfare, which I think a lot of the time is one of the sort of slightly vaguer points. Actually, the pass rates are extremely good. So I think as long as we conduct ourselves in a professional manner, it doesn't appear that a great deal of people are failing on that area. And one of the things I looked at, because I hold my hands up now, but I'm afraid I have next to no experience of in detail anyway, of the training you guys have had, the experience you guys have had. So what I was trying to do is try and gauge if there was a marked difference between the rates in the UK trainees and the non-UK trainees. And I think one thing from speaking to Zainab is there's certainly a feeling that the clinical communication tends to be an issue which isn't tested in these 4 stations. But actually, if you look at the difference in the pass rates between everyone and the UK trainees, there is a significant difference, but it's not as outrageous as you might think. So I think we'll speak about some of those things. But the reason I brought this up is, whilst we can go through a lot of sort of tactics and approaches and ways I would look at things, going through this exam, I'm afraid there is going to be no getting away from the fact that you need to be seeing lots of patients, you need to be identifying lots of signs, and that remains to be a major sticking point in people getting through PACES. So, and I think that is going to be an area which we will struggle over teams to do. So I think we will talk more about the process, about how you may be able to optimize the information you do get, how you be able to present it in a manner where you get the maximum value for that. But the first sort of point I would make is that in the run up to PACES, you need to be seeing huge numbers of patients, and you need to be getting really confident identifying these physical signs. Before we go through some of those bits, and that is sort of backed up on some of these graphs. So these graphs effectively compare the mean score and the pass mark. And as you can see, in that identifying physical signs, the mean score, the average score is very, very close to that pass mark there. So this is an area which, whilst I don't think in this form we're going to be able to do a huge amount, is something you need to be focusing on. So if people hear crying, I apologise. My son is upset about going to bed. So I apologise about that in advance. So moving on. So looking as we approach PACES and as we approach the clinical stations, I think it's important and helpful to know how you are being marked and how you are going to be assessed on this, because I think that can have an impact on how you, not necessarily how you may get that information, but certainly how you should present it. So when there are numerous videos on YouTube in a variety of places, I would suggest you look at some of them which actually focus towards PACES examiners, because the process on which you will be assessed from your physical examination, but particularly identifying physical signs, is primarily for a process called calibration. So this is effectively your examiners are going to go in, they're going to assess and examine the patient themselves, and they are then going to determine signs which are essential for you to find. And the MRCP makes a very clear point that for identifying physical signs, this is relatively cut and dry, in that if you don't find any signs which are deemed essential, or equally you find signs which aren't there, then you can start accruing quite significant negatives in this area. So the way we can help ourselves with this in this kind of area is that, one, obviously you need to be confident looking at these signs. You need to be able to identify these signs, but it's also the way that we narrate ourselves whilst we are doing our examinations. So this is where exams deviate somewhat from real life, and the examiners can only mark you, they can only give you benefit for signs, things you find based on you informing them that you found them. So whereas in real life you will do this examination, you will be thinking what's going on in your head, you won't be speaking out loud. When you are going into these exams, you need to be, I would say at the least, narrating what signs you have found, because the examiners may well have a small or moderately sized list of essential signs, and you effectively need to be making it really, really obvious to them that you have found those. So, when you are doing your cardio station, if you're like me, you get lucky and you have a metallic heart valve, which you can hear from outside of the station before you go in, you might think that it's absolutely blatantly obvious that this person has a metallic heart valve, but until you say that out loud, until you report that, it's next to impossible for the examiner to give you the credit for that. So there's two main moments in which we can do this, and the first is, as I say, narrating as you do your examination. If you get through your examination, you have a second sort of safety net, but obviously when you are presenting your findings, you then will also be making clear the signs you have found. But I think you will make your life easier and you will make it more straightforward for the examiners that as and when you find these signs, you are informing them. Other things you can do around that is, whilst they are primarily in that first 6 minutes assessing your physical examination and identifying physical signs, through practice, once you've got these examinations down pat and you're not really having to think about what you're doing too much, it is a situation where you can start to supplant a little bit of additional information. So you can show your knowledge through your narration of these things. So when you are auscultating your heart valves, you may say, I'm now auscultating I'm auscultating the aortic area. I can hear an ejection systolic murmur, which is radiating to such and such. This would immediately be making me think of aortic stenosis, and you can use that time, if you can get slick at it, to start interjecting bits of information which may benefit you in the different domains, such as your differential diagnosis and clinical judgment. Now, the slight counterpoint to make to that is you need to be confident that you're going to get through the examination in the 6 minutes. So obviously you'll have a 5-minute warning, and you want to be making sure that you're getting through at least the core examination in that time. At the end of that examination, if there's anything you've missed out, you can ever so slightly lessen the blow by saying, I would like to complete my examination by, examining hernial orifices or, checking for pedal edema. But these are all things which will just come with practice and making sure you're really slick. And I would say, whilst you're doing that, trying to get into the routine of narrating your action will make your life easy, because if it's not something you do normally, and it's not something most of us do, it can be a little bit foreign when you start. And it does sometimes highlight that, particularly for someone who occasionally trips over their words like I do, you can almost develop a degree of muscle memory with these things. Once you've said something, 20, 50, 100 times, invariably it flows a little more easily and it makes everything seem more slick, more professional. And when they're looking at the physical examination, the criteria they are setting, is thorough, fluent, professional. So it's not simply the outcome. There is a large degree of how the process appears to people. So that's the first point I would make around the calibration. Now, as we move through, the timings for these exams, as they are at the moment, is relatively thick. So you have your 6 minutes for examination, then you have your 4 minutes for your sort of viva, your Q&A at the end. Now, you'll get the 5-minute warning. So in that last minute, you need to be making sure that you have got through all the core bits of the examination. And then, whilst it's not 100% set in stone, you will pretty much always be asked present these findings or summarize these findings, and what are your differential diagnoses? Now, bearing in mind that in this second portion of the exam, you only have 4 minutes. Now, depending on how much knowledge you have on that area, I would imagine most of us could speak with reasonable fluency about areas we know well without overreaching too much for, you know, 2.5 minutes. So I think certainly when I was going through these exams, I think in the differential diagnosis, what you need to be what you are focusing on in that 4 minutes is the differential diagnosis domain, the clinical judgment domain. Now, if in the process of presenting your differential diagnosis, you can also supplant and show large amounts of medical knowledge, such as explaining between your differential diagnoses, you know, I think this patient has CKD because they have a arteriovenous fistula. Most likely causes for this based on the examination could be polycystic kidney disease because they have large portable kidneys on both sides. Alternatives to this, and by building on your differential and explaining between your differentials, you are showing your knowledge, but you are showing your knowledge somewhat on your terms. So I think it's an area which is worth having in your mind in that last minute of that physical examination. One, have I got all of the signs which I need to differentiate between my differential diagnoses? And two, how am I going to try and present these differential diagnoses in a manner which best shows my knowledge? So you could legitimately say, you know, my differential diagnoses here are polycystic kidney disease, you know, congenital single kidney or pyelonephritis. That would be entirely legitimate, but again, wouldn't show the level of knowledge you may have. So expanding on those, talking about why you feel one thing is more likely than the other, talking about why your signs would point to one direction or another can be helpful. Now, in addition to that, one of the advantages of you offering more information in those two initial known questions is that, and this is where my learned colleagues may feel differently to me, but I feel that PACES, it's the 4 minutes questioning isn't, from my experience, a hugely rigid process in regard to the questions. The examiners have some degree of leeway in questioning you, trying to get the information they want. So if it effectively means that you have some degree of influence over where your questions are going. So by laying out your differentials in sort of a thorough and well thought out manner, you also have the possibility of moving the questions in a direction which may be more suited to you. Now, I realise I've sort of been waffling off the bat for about 10 minutes. So before we sort of move on to some other bits, any questions, any queries, any thoughts on any of the bits we said so far?
Thank you, Luke, for this a nice introduction. So I totally agree with you. If you have a structured approach and you can, in a structured and systematic way, summarize your findings and present them in a way that shows you know what you're saying, you will give less chance for the examiner really to ask you any questions. I'm not sure if Dr. Dhikra Al-Wattar would like to add anything. She's one of the PACES examiners in the UK. Dr. Dhikra?
Good evening, everyone. Thank you, Dr. Luke. It's a very nice presentation, and you are talking in a very clear language, and it is very to the point. And that's what I expected from you today, is to go through more important issues. Yes, I know that the clinical part of the exam is the main thing and very important, but to go through these skills and how to be assessed and what do we mean by calibration and many other things are very important for any candidate from our background to pass the exam. I have no doubt that there people from that background, Iraq or the Middle East or Far East, they are very good clinicians. They can get the clinical science correctly. But when they come to presenting themselves or in the communication skills, they hesitate and they may fail. And that will give the high failure marks in these stations in this part of the world. Very different to the scoring while in UK. So, thank you for that. It's been done very clearly. I would like to expand on the skill A, which is the physical examination. And of course, it has to be very practice make perfect, of course. So they need to go through very good technique and not to miss important things where they can be failed easily. For example, they do everything right, but they have examined the heart from over the clothes. And this is a clear failure. They are not allowed to do this. So physical examination is skill A. If they examine the patient and listen to their heart from over the clothes, even if they get everything right, they will fail. No way. And this applies to station 1, station 3, and station 5. Of course, in the future, it will change, but I think these skills will remain as very important things. Another thing, in skill A, they have to be very systematic and they flow like someone very professional. They examine each system in a proper way. So suppose station 1, respiratory and abdomen at the moment, they have to examine the respiratory system in a very structured way, and they don't miss anything or jump from one place to another. So these are the important things in skill A. Why do the people fail in this skill? Is because they are probably not that practice in this the way we expect them for the exam, and they are a bit hesitant and not sure of what they are saying. This is very, the first skill which is not linked to the other one. Coming back to identifying physical signs, as you mentioned, it is one of the most important skills to be assessed in station 1, station 3, and 5. Because if they get wrong clinical signs, or they don't find the right clinical signs, or if they find clinical signs which we have not calibrated and not there, they will have unsatisfactory mark. Is this clear? So identifying clinical signs, the correct one, is a vital thing to pass this skill. And because its importance comes because once we miss the clinical signs which we agreed to as examiners, we cannot give them the pass mark in even if they give the correct diagnosis. If we are very empathetic with them, we may give them borderline, but they will never get a satisfactory in a skill D and even E, because they will give wrong diagnosis and differential, and they will request investigations which are not meant for that exact diagnosis. Coming back to a very important point you said, Dr. Luke, that yes, the good candidate can direct the examiner the way they like to the area where they know better than other areas. Yes, that's very correct, but we should remember as examiner also, and as a candidate, that we have like 5 skills in station 1 and station 3, and 7 skills in station 5. We have time, we have to ask about each skill. So it is not the time to show their knowledge, because the knowledge has been tested in part 1 written, in part 2 written. We are not after, we know how solid is the knowledge of someone coming to the PACES. We want to see how practical and how practice and how professional in their exam and the way they speak is what we are assessing. So it's the duty of the examiner to say, okay, now this is your diagnosis. What differential? They may say 1 or 2. There is no time to say it is polycystic, because I think I could not go give more information. No need, because that maybe goes into a differential diagnosis of hepatosplenomegaly, and then the examiner can say, and why it is not hepatosplenomegaly, and they can expand on that, because they have to move on to the next skill where they need to assess investigations, and they need to make a management plan, and they have to make sure that the patient is well looked after and safe, because skill G, as you say in your graph, everyone passes skill G, but it is the most difficult skill, because if you remember from your exam and from what we make sure that is, if someone fails skill G and an examiner give them a borderline or even unsatisfactory, this is the only skill the two examiners need to discuss the result together. Other skills we assess, we should mark independently. So the candidate need to know that they are assessed by fair people, and we don't sit together and say, okay, what do you think? Shall I give him satisfactory? No such things. Only in skill G, where we can, if I think this doctor has made a little bit of harm or said something which can harm the patient, whether verbally or physically, I should mark him unsatisfactory. And this is the only skill where we have to refer for counseling. If two examiners fail the candidate in this skill, no matter what is this candidate score, he should fail and be referred to the Royal College for counseling. So I'm just giving this, sorry, I always take long, but the subject is very, is very rich and the time is very limited. And that's what I wanted to say. And thank you. You done the presentation as Zainab, as Dr. Wataq before. I am very interested in listening to you presenting this PACES exam preparation.
Yeah, so I completely agree with you in regard to the maintaining patient welfare. I think you can probably split that up into sort of two main elements during the exam. There's the maintaining the patient welfare during the exam. So this is making sure that you're not causing them undue discomfort, that you're asking whether they have any pain before you examine them, that you're giving them prior warning before. You know, we've just done the medical school finals exams, and the number of medical students who, under the pressure, decide they're going to stop feeling someone's thyroid without telling them when they're stood behind patients that they're going to come and grab hold of their neck. I think under the pressure, it is something which can sometimes slip by. And then, as you say, the second sort of element of that maintaining patient welfare is making the appropriate, safe and sort of considered plan. So I think the first part of that is partially just practice and getting into the routine of doing those things. And the more you can commit those things to sort of muscle memory, because I think the other thing which we often tell the students in these kind of circumstances is when you're calm, relaxed, doing this in a, you know, in a ward environment or in a simulated environment, that's probably not going to be how clearly you're thinking when you're going to the exam and you've got the examiners sat across from you. So the more of this which you can do without thinking too much, the more mind space it frees up for you to be thinking, okay, what do I actually think is going on here? What else do I need to be finding? But I was genuinely surprised about the pass mark for that maintaining patient welfare, because I've heard of numerous people absolutely panicked about that area, and to see it being quite so well done took me somewhat by surprise.
Yeah.
So I think the next bit we can perhaps speak about is sort of an approach to presenting our findings. And I think this is perhaps where there's some variation from sort of place to place and person to person. So I'd welcome people's thoughts. What approach do the people think they're going to take to? So they've done their examination. The examiner's asked you to present your findings. How do people think the best way to go about that is?
So anyone would like to participate?
Okay, maybe no one wants to put their head above the parapet just yet. It's
yes.
So
maybe you could start, and then we can wait for the questions while you start talking.
So, I mean, there's a number of ways you can structure how you present your findings. But
so,
I think
Luke, sorry to interrupt you. So one of the participants, Rand, mentioned that the way you present is mentioning the positive signs first, and then mentioning the important negatives. Is that a good approach or not?
Yeah, so I think probably the most common way is, presenting your positive findings first, presenting your important negative findings. The slight advantage of doing something like that is presenting your positive findings tends to be more straightforward in that you're presenting what you've found. And the key when you're doing this is trying to present the relevant findings. So at some point during this presentation, you need to have in the back of your mind what differentials you're going to be proposing next, because the relevance or the pertinence of some of these negative findings in particular will be dependent on what your differentials are. So, certain all of the positive things you find, you're likely to want to present. So that bit can be relatively straightforward, but which negative findings you present as relevant is likely to be related to your differential. So I would say presenting your positive findings you can do in a relatively organized manner. Some people will present pathognomonic findings first, because often that's what's in the front of their mind. Equally, you could present them in something of a chronological order. You could go through your examination, albeit with that you may not be presenting the most relevant findings first. If someone's got a stonking heart murmur and you present this as the 5th or the 6th finding, it may not appear quite so fluent or so slick. But I don't think that's hugely pressing. And then, like I say, whilst you're then presenting those positive findings, you can then be running through in your mind which negative findings are important to know to separate out my differentials. Because that's the bit which, when you then go through your differentials, makes you look particularly slick, because you have already effectively shown that you know why things are more likely to be something than the other, and you've already presented the findings which differentiate for you between those options. Yeah, so like I say, most people will do the positive and negatives. I think in most PACES cases, there will be something, if not pathognomonic, very suggestive, which will be the sort of backbone of why you feel that is the particular presentation. So I think it's entirely reasonable to lead with that and have your other findings supplementary. And then moving, if we present our findings in that kind of manner, it then rolls on very smoothly to our differentials. So the other thing I would say, particularly when we're dealing with differentials and we're starting to move into your sort of practical application of knowledge here, the other thing we have to remember about this exam is, as with most medical exams, in a lot of ways, this is an exam of competence, not exceptionalism. So you being exceptional in one area won't cover up deficiencies in other areas. So the focus when we're preparing for these things is to show that we are competent and to a good standard in all areas, as opposed to being exceptional in one and deficient in others. So when we are looking at differentials, it is important to list common and important differentials, as opposed to necessarily trying to overreach with very rare or very what's an appropriate term, very high thinking differentials, shall we say, because as we said, as Dr. Al-Wattar mentioned earlier, this is an exam where you're effectively trying not to lose points, as opposed to an exam particularly where you can gain yourself a huge amount of additional points. So any thoughts, any questions, any other approaches people feel they would take to presenting? Yeah, Rand?
Yes, my question is to Dr. Al-Wattar, or to you as well, is as from an examiner point of view, what is the appropriate way to present our findings? Because I was thinking, if we present the positive and also the important negative in the same time, maybe the examiner would be distracted and he wouldn't be able to hear the important points that he wants to hear. So this is my question.
Okay, very nice question, Dr. Rand. Of course, start as we agreed, we start with the positive findings. And if the examiners are, most of the time, are fully awake and they are not distracted or anything, if we find that one of the examiner is not to that standard, I think the other colleague should make a note and tell the chair of the exam. So just be assured that the two examiners you are going to see in each station should be fully awake and fully aware of the candidates, what they say. What we do in the exam, one of us just listen to what is going on, and the other one is the lead examiner. So they will start questioning you. So we've been like, let's say station 1, I will take it as an example. Station 1, you examine the patient and the patient is short of a breath. The scenario says shortness of a breath. Please examine the patient. So you will concentrate on the respiratory system, testing everything related to that particular system of the body. Not forgetting that you look for the inhalers if they are around on the table, or if there is any oxygen cylinder nearby. So you need to be fully awake, looking at all these things, which can give you a hint of what is going on. And then you go systematic in a very fluent way, examining the face, the hands, the flapping, whatever you do. So in these 5 minutes, we are watching you very clearly what you are doing, examining him, asking him to cough while listening to the bases. It will tell us, without telling us, that you are probably listening to crackles at the bases. And you ask the patient to cough to see whether these crackles are permanent or they are changing due to secretions or whatever, bronchiectasis, whatever. So without talking, by examining the patient, you are telling us what you are doing, and a good candidate will be probably picked up by these two examiners, and while you talk, we mark. When the 5 minutes finishes, we will tell you that you have 1 minute to carry on. And sometimes you have finished and you can start the discussion. And sometimes you say, can I return back and examine? And we say, yes, you have another minute. Then by 6 minutes, you stop and we will start asking you. The first thing we ask you, what did you find on a clinical examination? Don't waste time to say, okay, this patient is just, I could not find cyanosis, or these are very important negative, maybe you didn't find them. But if you have found that something very positive, like, yes, he is short of a breath at rest, there is oxygen cylinder here, and I hear the crackles at the bases. And then, yes, so that is important. And beforehand, what we have done, we have calibrated this patient, me and the other examiner, the two examiners. We have found on calibration that this patient has a clubbing of the fingers, so we write it down. We find that this patient is centrally cyanosed, the tongue is blue. And we find that he has crackles at the bases, which has not changed with cough. So these are very important points. The candidates should have get the three of them to pass. So if you say that I could not hear any crackles in the bases, I think this is very clear failure, because that can change the diagnosis. Or if you say, or you don't ask the patient to cough, again, that can probably make you more borderline. You need to be very careful on what you find on a clinical examination, and not to say something you are not sure of. So if I say to you, and what about the left side? Did you not hear also crackle? And you may say, oh, I think maybe there was some crackle. This is hesitancy, and this will make you that you are not sure of what is going on, only on pressurizing you, you are inventing crackles which may be there or not there, and we will fail someone who does this. So the exam is very easy to pass. Let's put it that way. I don't want to be accused of being very harsh. The exam is easy to pass, but at the same time, you need to be prepared for this exam. In England, the driving examination, the driving test is like acting. You have to show the driver who is assessing you that you look, turn your heads left and right, you look in the mirror 3 times or 4 times, just to show them without talking that you are a competent person who knows that these movements are important. And this is exactly like the MRCP. You need to prepare yourself for the exam. There are things you have to say. There are things you should never say to avoid failing the exam. So in summary, Dr. Rand, start with the positive things if you are sure of them, and avoid things you are not 100% sure of it, because it may count against you. I hope that is clear.
And
I
would just slightly echo the point of being a little bit of the performance. One of the things we say to the medical students, and the exam, whilst obviously of a different level, the approach isn't all that different. You know, you already should have the knowledge by the time you get to this exam. This is your, this is you showing that knowledge you have. This is there is a performance element to this. You need to make it as obvious as you can. And this at times may look odd, but when you are, when you're approaching the patient, you stand back, you make a show. I am inspecting the patient from the end of the bed. I am looking at the things around them. I am looking on the bedside table. I'm not, so much in the same way that when you're driving your car, you're not spending the whole time turning your head looking in every mirror, but you would do in the driving test. So slightly kind of making it as easy for the examiners to see what you're doing, and is a good way of going about it.
Thank you, Luke. And may I add to your point that, and to Dr. Al-Wattar's point, is just avoid being prompted. And that's what we mentioned in the first session with Dr. Wathiq. Please say the findings in full and don't wait for the examiner to prompt you. There is a question, I wasn't sure if I got it right, from Abdurrahman's asking is, does the reading what we find of clinical signs and medical history from the paper affect our evaluation as examiners, or should we list it verbally without writing? He's asking about examiner evaluation, but I wasn't sure because usually examiners don't read from papers, and the candidate who present also doesn't read from any paper when they present in the clinical station. I'm sure if you could verbally ask the question, maybe we could understand what he was trying to say. Dr. Abdurrahman. If there's anyone else who would like to participate, or Dr. Abdurrahman, if you want to tell us your question, like speak it out loud. Okay, fine. I mean, I think we can move on now if no one else would like to participate and start with the clinical stations, Luke.
Okie dokie. So this is where I think doing this via Teams starts getting somewhat tricky. So we had some on my presentation. I had some scenarios laid out, but obviously we've lost those. So Zainab has very graciously sent me over the cases for PACES. So we can perhaps try and have a look through a couple of these cases, and we can think about how we may approach them, how we may approach presenting them. But I think the first point I would like to make is, first of all, if people haven't got something resembling cases for PACES or something similar, I would suggest that you acquire it as much as anything, in that when you're preparing for an exam, it is worthwhile thinking which patients are going to be coming into the exam, because all of medicine, a large portion of medical problems don't present in a manner which is particularly conducive to be examined in a PACES exam. So the kinds of cases which are predominant in PACES are people who are stable, and by that, more often than not, that means people who are chronic, and obviously people who have signs. This is an exam of a clinical examination of finding physical signs. So when you are assessing patients in your hospitals, in your clinics, you know, it is worth bearing in mind when you're examining, when you are finding these signs in real life, you know, what kind of patients could we get into an exam? Bearing in mind, a lot of these, the vast majority of the exams are happening in outpatient departments, are often happening at the weekend. So these are going to be reasonably stable patients, but with significant signs to find. And that kind of criteria does narrow down a little bit the kind of patients who are likely to present. So the kind of people you may be seeing in your resuscitation department, you may be seeing in your inpatient hospital beds, may not necessarily be the kind of patients who are following through in the PACES exams. And by getting some of these clinical cases books, it can give you an idea of the sort of core presentations that you really need to have locked down, and you need to have a real degree of confidence, because it's not that they can't assess you on pretty much anything in PACES, they can, but certain scenarios are invariably going to be better fits for the exam, certain types of patients are invariably going to be more straightforward to acquire. So, you know, conditions which are 1 in 100,000 invariably probably aren't going to come up as much as conditions which people are seeing in their outpatient clinics a bit more frequently. So bearing that in mind, there's a number of these kind of texts out there where they effectively give you written cases to run through. And like I say, they will give you a list of reasonably PACES specific sort of cases. So when you're looking at abdominal, you know, in PACES cases, they're quoting, you know, chronic liver disease, hepatomegaly, hepatosplenomegaly, hemochromatosis, renal enlargement, transplant patients, in PACES in general. Scars are always a great thing. If you're not confident in identifying scars for most of these common conditions, I think that's something which is well worth looking into. You know, in the abdominal respiratory here, you know, pulmonary fibrosis, bronchiectasis, there's a lot of patients with old TBs with or without lobectomies around still. Although, you know, those numbers certainly in the UK, if you come to UK centres, are heading down a little, but there's still a good number of people around. Things like chronic obstructive airway diseases, pleural effusions, obviously relatively stable cancers, things like your cystic fibrosis. I mean, they've listed pneumonia here. I mean, unless you had a particularly sort of chronic organizing pneumonia, I think, unless they've gone and pulled someone from the ward at short notice, which I certainly know we do in our versions of the exams. My PACES examiners may be able to tell me otherwise, but I would imagine, as in other exams, occasionally patients don't turn up and have to be acquired from the nearest source. So that you may get some slightly more acute things from that side. And then, you know, moving on to cardiology, a large portion of these are going to be murmur related. You know, if you're not really confident and locked down on your cardiac murmurs, and both identifying them but also describing them and describing the differences between them, because they're a integral skill to acting as an independent registrar, really, and they are often long-standing, stable, chronic. Patients can be reasonably well, so can come in for the examinations reasonably easily. Any implantable devices, you know, pacemakers, reveal devices, and then moving through. I mean, neurology was always the one which struck the fear of God into me. One, because even to this day, getting through a sort of thorough and complete cranial nerve exam in 5 or 6 minutes, I feel like you have to be reasonably slick. Obviously, it can certainly be done, but it's certainly, when I was preparing for PACES, it was one of the areas where I spent significantly more time. Although interestingly, on the graphs they presented previously, that sort of feeling for me didn't really pan out in the pass rates. The actual pass rates across the 4 clinical stations are relatively similar. Neuro is ever so slightly lower, but I would imagine not to a degree of statistical significance. And then again, the kind of cases we're looking at are obviously cases, you know, stable, lots of signs to find. So neuro is going to be rife with these, really. Your multiple sclerosis, your stroke, your Parkinson's disease, and a number of these conditions as well. This will obviously potentially change a little bit with PACES 23, but a number of these conditions also fit reasonably well into the station 5. I had a Parkinson's disease in my station 5, and I mean, I really couldn't have asked for anything more straightforward. You walked into the room and you could already see his small writing on the paper in front of you with a pill rolling tremor. And there's nothing quite as reassuring when you're feeling stressed, of feeling confident you've got the diagnosis before you've sat down in front of the patient. So that's always nice. So moving through, so we can try. We've spoken a little bit about that. And effectively, what you're wanting to do, and when we're going through these kind of things, this plays in a little bit to the presentation we were speaking about as before. So if whilst you are doing your examination, or before you've done you've made your presentation, if you've got a reasonable idea of what your differentials are going to be, that can help guide you. And I've had a couple of private messages about which negative findings to put in. Do we list all the negative findings we have? And I would say that when you're going through these kind of cases, you need to be the negative findings you need to be listing are the ones which are going to help you discern between your differentials, or things that you would potentially give you an idea of severity of your differentials. So when we're looking at something like chronic kidney disease and hepatomegaly here. So as you're going through your exams, you're going through in a systematic manner. So you're going to approach the patient, you're going to make a show, you're going to wash your hands. If you're not walking into the station already washing your hands, you've missed a bit of a trick. You need to introduce yourself, you need to explain who you are, what you're doing there. You need to position and expose the patient. And I would also at that point also ask the patient if they have any discomfort, any pain, because this immediately shows that you are, maintaining patient welfare, you're maintaining patient comfort. The fact that they have some pain and discomfort doesn't necessarily mean that you're not going to do that portion of the exam, but it's certainly helpful to know that before you get in. And again, it's showing that you have that consideration for patient. So, you've approached the patient, you're looking at the end of the bed, you're looking at what's around them, certain examinations, there'll be more there. I think as Dr. Attar said earlier, respiratory, are there inhalers, are there nebulizers, are there oxygen, and the things around the bed. Other areas, there may not be so much paraphernalia around the patient, but again, make a show of looking, go up to the patient, and if you're not confident you're going to do it, take a step back, say, I'm inspecting the patient, I'm inspecting the surroundings. This is your driving test equipment. This is looking in your mirrors, you're making a show of what you're doing, and then you're going through your examination in a systematic way. So you're looking at the hands and you are commenting on findings which are applicable to that examination. So obviously with your hands face, you don't want to be talking about the same kind of signs in an abdominal exam that you would necessarily in a respiratory or cardio exam. So you want to be targeting your narration to the examination you're doing. So when we're talking about chronic liver disease here, they're saying, looking at general, are they cachectic? Can you see icterus? Is the sign of excoriations? Is the bruising? You're going to look at the hands, you start at the nails, are you looking for leukonychia? Are you testing clubbing? Obviously things like Dupuytren's contractures probably wouldn't be something you would mention in the other examinations per se, or certainly wouldn't be near the top of the list. Palmar erythema, you may mention in your abdominal or your cardiac exam. It may not necessarily be on the top of your list in your respiratory or certainly your neurological exam per se. So you've looked at your hands, depending on how your timings is, people can, you can then move up and feel the pulse. Again, this may be something which is certainly more applicable on a cardio station. You could argue is not necessarily as applicable in an abdominal case. But you need to be showing that you're doing this in a symptomatic way. So, you're looking at the hands, you may not be feeling the pulse. You may then suggest, if I would offer to check a blood pressure. You're then moving up to the face, you're looking for signs again of the associated condition. So in this, they talk about, the theta hepaticus. I mean, a lot of these smells in the post-COVID period, I think, are and again, Dr. Attar will be able to comment on more on this. I certainly think from when we're dealing with the medical students, I don't think you would be expected in a post-COVID era to be putting your nose within an inch of someone's mouth and nose to be smelling for pear drops or smelling for anything else. But I may be wrong on that. So you're looking, and then when you're looking at the face again, you're looking systematically. So you're looking at the eyes, you're looking for jaundice, you're looking for xanthelasma. You're looking in the mouth, you're looking at dentition. If you're talking about, particularly talking about cardio, you're checking the dentition, you're checking for any lumps and bumps. On particular exams, you may want to offer lymph nodes. Are you doing respiratory? Are you wanting to check pancoasts? Are you wanting to check for particular lymph nodes? You're then at this point, you should already have them appropriately exposed, but you're then inspecting the area. So on this, you're then looking for the chest and abdomen. You're again commenting on findings which are applicable to that exam. So, reduced body hair, gynecomastia. I think if you're inspecting the chest and the abdomen and you're commenting on testicular atrophy, people may look a bit funny at you. And then you're moving on to your systematic exam. So, for the abdomen here, you're doing your palpation, your percussion. And again, much as you want to be making it very obvious what you're doing and where you're doing it, because as part of your physical examination, if you know where you should be palpating for these things, why not say it out loud? You know, the examiners are watching, they can see what's going on, but if you already have that information, say, you know, I'm auscultating in, you know, mid-clavicular line, second intercostal space, tell them what you're doing if you have that information. And you're going through in a systematic way. So, you know, as I say here, with your palpations, you're going to palpate, you know, across your 9 areas. You're then going to palpate a little bit deeper. You're then going to palpate for your individual organs. So you're going to palpate for, you know, a liver, a spleen, some kidneys. You then may also percuss for those. So I find, particularly in the context of, you know, liver and spleen, percussing out a liver edge can be really quite handy. And again, doing this in sort of a logical manner is appropriate. Then you're moving through to your auscultation, so you're listening for your bruits. They've said here listening for a bruit over the liver. I think that would be a reasonably uncommon finding, but it's something that you can say you're doing. Certainly listening for renal bruits in certain cases would be handy. And then moving, so you're moving, and then you may move down the body further. So you may look for your pedal edema. You may again look for excoriations or any signs of jaundice there. So the key in moving through as you're conducting the exam is making sure you do it in that logical, that sort of fluent manner. One, it makes your life easier because you can be confident you're not missing anything because you know you're going through your routine. But also, it really comes across like you know what you're doing. When you go through things in an organised manner, you're not having to jump back. It just makes it clear you know what you're doing. You're not missing things. You come across as professional, slick, and that's what you want to be doing. Now, when in certain conditions, as well as your differentials, there may be some information you want to try and garner around severity of that. So, you know, when they're talking about chronic liver disease here, you may want to be looking for evidence of decompensation. When you're talking about what are we thinking? If you were talking about pleural effusions, if you were talking about pneumothoraces, you want to be able to be plotting those out and giving an idea of severity or extent of those. So, any questions, any queries? I'd be keen to know what Dr. Al-Wattar feels around what I've said, because as I say, I'm a fair way from a PACES examiner, so please feel very free to completely disregard some of the things I've said.
No, I think, Dr. Luke, you have gone very thoroughly through what is expected from a candidate. The most important thing these candidates need, of course, as we said, they have the knowledge, they need to practice for the exam and time themselves, because the time is very, I mean, if we have 10 minutes to examine someone, we will go, of course, very thoroughly on everything. But when we have only 6 minutes, we have to time ourselves and do it quickly. And this comes only with the practice. So every time the candidates who are sitting the exam have the chance to be with a patient, they should imagine themselves they are sitting the exam. And it will be even nice if one of their colleagues is with them, or even their senior or their mentor is to say, can you kindly time me while I examine this patient? This is very important to check the time and be very thorough and very professional in these 5 minutes to check on all these things. What you have said about the scenario of like station 1, let's say the abdomen. Yes, very important to look at the hands, the face, if there is hepatosplenomegaly, they should look, but also not to forget to percuss for the presence of ascites, because even if they think there is no ascites, they have to show the examiner that they are looking for one, and this is very important. it's the same as with other station. You mentioned the neurology station. The neurology station is, of course, when I was preparing for my MRCP exam, they used to say, if you want to pass your MRCP, you should pray for a long case in neurology, because even the examiners are not that good in that. So coming back, so coming back to the station number 3, which is in neurology, the candidate should also look, because sometimes you can see an artificial leg is on the side, or the patient is probably in their beds, and the scenario say, please examine this patient, because on the wall they put a piece of paper, say, this patient has difficulty in walking, please examine him. And the patient is very comfortable in bed, semi-recumbent, covered everything, and the candidate has not noticed that there is an artificial leg on the side, has not noticed a wheelchair on the side. And then when examine the patient, they don't even say, I would like to see you walking. And this is very important in this station. If someone coming with difficulty with walking, they should, first thing they can do before the time finishes, please, can I assess your walking? Can I see you standing up? Can I check your posture or gait or whatever? And this is very commonly coming in that station all the time. Of course, peripheral neuropathy is number 1, as well as your case, which is very common, and it can come in station 3 and station 5, the Parkinson disease. It is very common, and it is very good clinical signs for the candidate to find, and it can vary from the beginning of the test, like in the morning, the patient has taken the medication, and we can hardly see any tremor or any stiffness or anything in the joints, while as the exam goes on, by the last candidate, some more tremor can be seen, and some more rigidity is more obvious. So I think, yes, the neurology cases are needs to be looked at in a special way, but they are very easy to, I don't say easy to fail, easy to fail if we are not very clear about it. But yes, everything you have done very well, my dear.
Yeah, I mean, it's eight or so years ago now, and I still remember, I think I probably spent as much time on neurology as I did the rest put together, just because it struck the fear of God into me. So
Luke, shall I interrupt? Sorry about that. Shall we just, like, for example, give our candidates an example of how to present, say, a 60-year-old patient on hemodialysis who has a tunneled line or AV fistula? He looks pale, maybe there is a nephrectomy scar, some, I don't know, uremic features, euvolemia or hypervolemia, the way you design it, just an example of a case, how to present such patient.
Well, you put me on the spot there now.
Sorry, in 2 to 3 minutes, if that's okay.
So I mean, I think when we're presenting these kinds of things, like I say, what you want to be doing is, I would tend to start with some very brief demographics. So I examined, you know, Mr. Smith. He's a 60-year-old gentleman who presented to us with feeling, you know, weight loss and feeling increasingly lethargic. On examination, we have noted that he has a left brachiocephalic fistula, as well as some evidence of excoriations and some recent needling sites on said fistula. He also has some evidence of, what other signs could we say? He has evidence of a previous unilateral nephrectomy scar, as well as what appear to be previous failed fistulas on the right brachiocephalic side. important negative findings are that he currently has no evidence of a pelvic renal transplant. I could not palpate enlarged or cystic kidneys, and I saw no evidence of pedal edema suggestive of a hypoalbuminemic state or nephrotic syndrome. So I think I would, in my own mind, I would be approaching that in a manner of, we have a patient with CKD, we say the things which show us he has CKD, you know, he has a fistula, he has a failed fistula, he may be uremic, he has excoriations, he's uncomfortable. Looking at fistulas every day, I would tend to comment on whether I think it's being needled actively, because it will give you an idea. A lot of these people who are post-transplant will still have fistulas which are buzzing away very nicely, but obviously if you can't see any evidence of needling there, you may want to be making sure that you've not got a transplant hiding down in his pelvis. And then I would be looking at both, wanting to show he's on renal replacement therapy. So in my negatives, I would want him to be saying I didn't say it in that one, but you would say, you know, he doesn't have evidence of a peritoneal dialysis tube, he doesn't have evidence of a pelvic transplant kidney. And then additional things you would want to be talking about is differential potential diagnoses of his CKD. So that's why you may be commenting on whether he is evidence of nephrosis, you know, is he edematous, has he got evidence of a hypoalbuminemic state? Obviously, you're not going to have an idea about how much protein he has in his urine or how much blood he has in his urine, but you may also want to comment on any you know, ENT symptoms to rule out a vagus or an MPA. So I think that is, without actually having a case in mind, that is how I would go about it. But like I say, I think what a lot of this stuff boils down to is just putting yourself on the spot with both time and something resembling the pressure, and forcing yourself to actually say these things out loud, because we all think we can do this. And, you know, even just speaking about a subject which I know very well about, my presentation just then, I don't think was particularly good. There's lots of things, even just in the 2 minutes afterwards, I would have very clearly added. But by getting regular practice at this, and it's certainly something which you can get more slick and more comfortable with.
Thank you, Luke. Thank you. And I think with abdomen, we always need to remember to add the bit that I'd like to finish my examination by examining external genitalia, PR examination, and urine dip, maybe for protein and hematuria in your case.
Peritoneal orifices as well is often a good one, which you won't have time to do in your abdominal examination.
Excellent. Thank you, Luke. Thank you. Yeah, I think there's no question, so we can proceed to the next.
So how do we want to proceed? Because like I say, with the PACES for cases, it's not quite laid out in the format I had. So basically the answers are all going to be presented to people as we go through. So
yeah, I mean, I think if we could just imagine a scenario and then start talking about it, just like the one with the hemodialysis. I'm not sure what they feel about this, what our candidates feel, if anyone would like to say something. Maybe start talking about imaginary scenarios and how to present them, or is there any other thing you would like us to?
Telling silence.
Yeah. Let's see. Let's talk about, for example, what's your next? Was it? I can't see it because it's quite small. Is it respiratory or is it neuro?
Oh, let's see if. So
yeah, for example, so how to present an infective endocarditis, maybe, or a metallic heart valve case.
So I mean, the slight. Oh, what's happened here?
Dr. Al-Wattar, would you like to add something, or?
Just whatever you choose, maybe you prepared it better, but maybe you can go through station 5. Everyone, station 5, yes, there will be a scenario to read for 5 minutes before they go into the station. And there is always a hint in that scenario to focus on and to examine on. So probably we need to expand on what is expected from these candidates in station 5, how to approach this station, and how to divide their time, which is only 6 minutes, and we tell them they have 2 minutes left to answer all the questions and the concerns, and then leave us with only 2 minutes for the examiners to assess that candidate. If on the top of what you are going to talk about, I think station 5 is where all the skills are assessed and where the candidates find difficulty to when to start examining the patient, and maybe to start examining them while they continue to take the history from them. If you want to expand on that, I mean, think that is more.
I mean, I always thought, now I haven't read up intently on station 5, so I'm going very much from memory now, but I always felt that when I was preparing for station 5, that the approach to it, primarily because of the times you speak about, had to be somewhat different. And I always felt that whereas the approach to the 4 physical examination stations was about being sort of thorough, logical, and having kind of a reproducible approach, I think because of the time limits involved, station 5, you tend to have to be more targeted. So it is about, because you're dealing with a limited time, it is to a degree, it is about trying to efficiently gain the information or gain a differential diagnosis. And then as opposed to necessarily doing the entirety of an exam, it's about then exhibiting the signs and symptoms through the history and examination, which show and confirm your differential. So, for example, in Parkinson's disease, in my case, I mean, thankfully I was very, very lucky in that with both of my station 5 cases, you sort of knew what it was before you went to the room. So I had CREST syndrome, and you know, I think on the couple of lines outside, you had someone who has problems with cold peripheries in the winter and difficulty swallowing. So before you walk into the room, you already kind of know what you're dealing with. Equally with the Parkinson's, you could see his pill rolling tremor as soon as he walked into the room. And then I then proceed from there to get enough information from the history to confirm that diagnosis or to sort of solidify that diagnosis. And then you're then aiming to do a targeted examination to really show the signs related to that condition. So in Parkinson's, as opposed to necessarily doing a full and complete, you know, peripheral nerve neurological exam, you may be exhibiting, you know, the bradykinesia, the increased tone, the cogwheel rigidity, the micrographia, the cog, you know, the pill rolling tremor. So that was always my feeling about station 5, and that you had to have a mechanism, not quite of spot diagnosis, but a mechanism within the first couple of minutes of having a good idea what you were then going to try and do for the remainder of the station. But I'd be intrigued to know what, from the examiner's point of view, how you feel that should be sort of conducted.
From your talk, you said PACES 23 is going to change from the diet to 3, which meant to be in PACES 20, but unfortunately the COVID delayed everything. They have found that station 5 is very stressful, and it's very difficult to assess all the skills in this 10 minutes. And we have 2 patients, each one of them has 10 minutes, and it is very, it goes very fast and very difficult to assess all these skills effectively. So they have changed it, and in the future, in Diet 3 in UK, they will replace the communication skill, and they will make it like two separate communication skill. Each one of them is 10 minutes. So in station 1, just to tell whoever is attending the exam, I don't think many will have the chance to sit the current PACES in Iraq unless we do the mock next week. For the future, this is going to happen. Station 1 is not going to be respiratory and abdominal case like what we are doing now. It is going to be one communication skill and one respiratory. And then in station 2, it will be a brief consulting. Station 3 will remain the same, cardiology and neurology. And station 4, it will be one communication 10 minutes and an abdominal examination. And station 5 will be another short, brief, like station 5 now, but only one case. In the communication parts in station 1 and station 4, yes, well done, thank you very much, that's very ahead of me. In these station 1 and 4, there will be two communication 10 minutes assessment, but the examiner will not speak with the candidates. We will just watch them listening and talking to the patient, and we score them that way, not like what we are wasting our 20 minutes like in the communication skill now, 20 minutes just watching the patient to discuss only one scenario, and then we will give them further 5 minutes to discuss, and it's just they felt that it is not worth the assessment, and we need to give the examiners equal opportunities to assess the candidates effectively. So that's why the change is going to happen. So coming back at the current station 5, which is two 10 minutes exam, we have 8 minutes with the patient. The candidate has 8 minutes with the patient. And before they go into the station, they have to read the referred letter or whatever given to them, a task to follow. It is very important to focus when they go into the station on the information given to them through that piece of paper to read through, whether clinical signs there, whether blood pressure or whatever, because it's always there is a hint in that piece of paper where to focus on. So for example, a 30-year-old lady came with twice loss of vision, which has recovered now. Please assess this patient. And in the blood pressure is all normal, everything is normal, and she's only 30 years old, and she was twice lost her vision and now recovered. So you are the doctor in the station and you are going to assess this patient. So in this 8 minutes, the candidates should probably for 2 to 3 minutes explore the story of what kind of loss of vision. And while he is talking to her or she's talking to her, they should start assessing the patient, but not to examine her heart or listen to her lungs or to assess her walking. They should focus on examination of her eyes, whether she has any peripheral vision loss or central vision, and they should at least say, I want to have ophthalmoscope to look inside the eye. So this is what we are talking about station 5. They have to direct their taking the history and the focus examination according to the scenario or the whatever given to them in the piece of paper they have outside the station. So this is a station 5 at this stage, at this time. it's going to be changed completely, because it's not fair to have all these skills assessed only in 10 minutes. And not only that, the candidates should make sure that by the end of 6 minutes, they have to ask the patient, what are your concerns? Because if they don't answer the patient concerns and the worries and the question they have, that skill of, I think skill F is not managing patient concern, will not be marked properly, and they will score 0. So station 5 at this stage is this way. First, to read the scenario properly and write notes, what to focus on. Number 2 is to start examining the patient while taking the proper focused history, and then start summarize the things and tell the patient what you think or what they think they have, and make a plan of what is the next step from the management, whether immediate or future management. So, and the examiners only discuss things for 2 minutes to say, what did you find on a clinical examination? Because we have seen them examining and doing all these things, but they never said to the patient, I found that you have probably you have papilledema, or I have found that you have hemorrhages, or I have found nothing, whatever. So the examiner duty is to say, what did you find on a clinical examination? And I heard you arranging some tests. What else you will do apart from doing the blood test? They may say, I want to do MRI or whatever, or lumbar puncture, because this young lady probably MS, whatever. So they need to produce a good differential diagnosis and good management and answer the patient worries and concerns.
Thank you, Dr. Al-Wattar. And I, just to add to what you just said, and last week's session, I advised the candidate, we did a private session, that before you go to see the case in station 5, have a list of differential diagnoses, because this will guide you. So for example, in your case, otherwise, if you don't have a differential diagnosis beforehand, before you see the patient, you wouldn't know what to ask. You didn't know what to examine, and you'll waste your own time, because station 5 has to be direct, close the questions. Tomorrow we will have a station 5 session with Dr. Khalid, and we will explore a couple more scenarios, and hopefully we'll expand more on station 5. But yeah, if anyone has anything to ask, or Luke, if you'd like to add anything.
I don't think so. I mean, like I say, I can only apologise for my my technical frailties. It's
that's all right. Thank you for your time. I know. I mean, Luke prepared the presentation and he really worked hard on it, but unfortunately, technology didn't serve us tonight, and we had to go through a Cases for Paces book. But that's why your participation is very, very appreciated, because this session is for you. So if there's anything you'd like us to discuss or add or comment on, or please do raise your hands or unmute your microphone. I don't know if there's anything else you'd like to add, or Hamza, yes?
Hello, everyone.
Hi, Hamza.
Yeah.
I have a question. I'm sorry, I couldn't ask it earlier. Okay. So Dr. Dhikra mentioned that if we are the students, examine the patient with his clothes on, okay, we will get a failure mark in the exam. So there are some cases, some situations that we can't ask the patient to have a full exposed, or it will be difficult to full expose the patient, like if the patient was young woman, young lady, or if the patient, he or she, had certain beliefs that prevent him to get fully exposed.
Yes. Yes. Okay, Dr. Hamza, sorry to, do you have another question for me, or shall I answer you?
No, doctor, this is
Yeah.
all. Thank you.
So I really appreciate we are coming to an area in our country or in other places where cultural things are a barrier to us. But number one, first to have to take their permission, and the examiners will be there. We are not going to expose the whole body and keep it, which is not acceptable anywhere on in any exam. We are not going to expose the patient full whole chest for 5 minutes just to wait and listen for a murmur or basis of the lung. We have to cover part of it. What I am trying to say, don't examine the patients listening for a murmur from over the clothes. You can put your stethoscope and the examiner will fully understand and say, okay, you are allowed. Don't expose the patient, but put your stethoscope on the mitral area or aortic area or on the carotid area. And this not applies on the chest or abdomen only. You have to make sure that once you finish the exam, which is not going to take very long, you have to make sure that you cover the patients and make a decent exposure whenever needed. Another thing, I think last time Dr. Zainab or people examine the patient's neck. Neck is, yes, I know it may also be not able to examine, but you need to look at the neck by face, not from over very wrapped neck. You need to assess that. You need to listen to the carotid bruit. So in summary, yes, our culture is very respected and we should not expose the patient unnecessarily. And if it is impossible, we should respect the patient autonomy and we should not push hard. But I think it is not that acceptable if there is a murmur and the patient in real life coming to be examined by a doctor. I think they are prepared to be examined by, that's where a doctor is very honest person and allowed to examine anyone as long as they are respectable people. So that's my answer.
I mean, and a couple of bits I would say is, I mean, when it comes to the exam, these are patients who have agreed to attend for the exam. So it's unlikely they would be volunteering for exams which they feel are culturally, religiously, or personally inappropriate. And the second thing I would say is that if you are unsure, you can propose the level of exposure which is needed for the exam, and if it has already been agreed between the patient and the examiner that for whatever reason that isn't happened, the examiners will move you on and will correct you, but you should still suggest the appropriate level of exposure. You should suggest that, you know, the correct process, and if for whatever reason that isn't deemed appropriate, you've still shown that you know what that level of exposure should be. So I would still suggest that you need to do this with, obviously, with the consent of patient and with discussion with the patient, but one, they're not likely to sign up for the exam if they're not happy, but also the examiners won't let you do something which is an exception to the norm. So if for whatever reason you need to expose them to a certain degree and it's been agreed that that won't happen, you could still say, I would expose them to this, and the examiner will say, okay, in this circumstance, we're going to do it in this manner. But then you've still shown your knowledge, you've still shown what would be the appropriate routine.
Thank you, Luke. Yeah.
Thank you so much.
Yeah. Any other questions? I mean, it's difficult with the clinical station to do it virtually, but we're trying just to give you some tips and advices on how to present them. I'm not sure if you could comment on some of the things that we discussed beforehand, you and I, the terms we need to avoid, like, for example, how to explain an autoimmune disease, for example. Yes, just the language. That'd be better. The best language we could use to describe such things.
I think it's difficult, and I think it's one of the areas where you know, the difference in culture will invariably have more impact. But I think the thing we were discussing previously is you need to be aware, particularly in the sort of communication stations, that certain terms will be more emotion laden than others. So if you were taught, so when we have our students, we were doing a mock, myself and Zainab were doing a mock OSLA, and we had a student who was describing to a patient an autoimmune disease, and they said, so this is your immune system attacking and destroying your kidney or whatever it was at the time. And the patient who was presenting as a young patient, a reasonably vulnerable patient. And I think invariably the use of those terms, whilst not wildly factually inaccurate, invariably would potentially invoke some negative emotion. So being aware of how people may perceive the terms you use can impact on how you conduct yourself. So when I'm seeing my renal patients, when we're talking about whether we should offer someone another kidney transplant per se, patients who I know well and I know have been non-cooperative in the past, I will openly and intentionally use quite direct and quite blunt language, because you know them well, they know I'm coming from a good place, they know I want to do best by them, and I feel that kind of emotionally laden language is more likely to hit home. Equally, if you have had an 18-year-old just transferred from paediatric care who you haven't met, has come in with their parents and is clearly quite quiet and timid, you would approach that in a very different manner, and the words you would use would be different as well. So I think it is one of the areas which invariably, not being in UK practice, will potentially be slightly more tricky for you. But I would just say, sort of try and put yourself in the shoes of the person you're speaking to and think, if I wasn't medically trained, how would that make me feel? What would that invoke in me? And as the clinician, is that what you're trying to do at the time? So there may be times when you do want to upset someone. Some of our young patients who don't attempt for dialysis, they know full well what they're doing, and at times we will be fairly brutal with them and say, look, you are doing yourself huge amounts of damage here. There's only so many times we can bring you back from the brink. Like I say, equally, there's times when you need to tread more carefully, and choosing your language and choosing your words based on the sort of emotional impact they may have does help in the way you come across, both to patients but also to the examiners, because it gives that overall appearance of professionalism, whereby you are considering patient welfare, you're considering patient concerns, and it makes you appear sort of more appropriate to the circumstance. But I do think it's something which is very situation dependent, so it's quite hard to there's not a list of bad words and good words I can give you particularly, but what I would say is, try and consider the impact of your sort of choice of words, particularly when you're having these quite sort of pointed conversations.
Thank you, Luke. Any other questions before we end? Thank you for your time, Luke. I think everyone seems to be satisfied and there are no questions.
Thank you for having me. If at any point you think I can be of help, I'm happy to come back. Although if I do come back again, you will probably have to meet my daughter, because it took a superhuman effort for my wife stop her from coming and saying hello to all of you. So I will pre-warn you of that if I
She's
join
more
again.
than welcome. She's more than welcome. Thank you, Dr. Al-Wattar, for your. I always appreciate your participation with us. It's very, very useful, and it gives us a good insight from the examiner's point of view, what they think and how they evaluate candidates. So thank you so much. So if there are no other questions, I think we can wrap up the session and say good night.
If I can just say thank you, Dr. Al-Wattar, as well. It was very reassuring to me to know that there was a PACES examiner making sure that nothing I was saying was outrageously inappropriate or incorrect. So thank you for being my safety net and ensuring I didn't give any inappropriate information.
Look, I hope you and Zainab soon you will be examiners, and inshallah we will before I retire we can examine together, inshallah.
Hopefully, fingers crossed.
I will look forward to it.
It was really very good session, excellent session. Thank you so much. I mean, I am very pleased that you didn't have your presentation. Without the presentation, you did excellent things. So what would you have done more?
Well, it's always a bit of an emotional crutch, isn't it, having the presentation? So that's possibly more for me than it may be for you guys. But
no, you have done very well, and thank you.
Thank you. So tomorrow we have station 5. It will be with Dr. Khalid Abul Ainin. He's an acute medicine registrar. And after tomorrow, we will have an ethical scenarios, multiple ethical scenarios. Both sessions will be simulated sessions. I will be the surrogate, I will be the patient, and you will be the candidates. And our Dr. Al-Wattar hopefully will join us tomorrow. Hopefully, we will see you there tomorrow and after tomorrow.
I'll try my best, because we are probably by Saturday, we will be very busy traveling, but I'll try my best. And it's a pleasure to see you and participate in your lovely workshops. Thanks a lot.
Thank you. And on Sunday will be our last session, which is the history taking session before the exam. So see you all tomorrow and have a good night. Thank you so much.